Good morning, everybody. As usual, giving it just a moment for you to hop into today's Grand Rounds, but we also have an amazing topic today with amazing presenters on long COVID. So we want to get to that as well. I'll turn for Dr. Dunn, who has a brief update as well on the 1619 project.
Good morning. Thank you so much. As we strive to become an anti-racist department, I want to tell you about an event. The 1619 project is the New York Times Magazine's award-winning reframing of American history that placed slavery and its continuing legacy at the center of our national narrative. The project, which was initially launched in August of 2019 and spearheaded by Nicole Hannah-Jones, offered a revealing new origin story for the United States, one that helped explain not only the persistence of anti-Black racism and inequality in American life today, but also the roots of so much of what makes the country unique. To that end, on behalf of the Diversity and Inclusion Council, I invite you to join an engaging discussion of episode 1 of the podcast of the 1619 project, which is available anywhere you get your podcasts, and that's entitled The Fight for a True Democracy. That event is going to take place on February 15th from 5 p.m. to 6 p.m. And please stay tuned for details about the registration.
Great, thank you so much, Dr. Dunn. And I just want to mention, we do have a critical blood shortage at Stanford. So please keep that in mind, of course, as you're ordering blood products. Also want to just throw a shout out, at 500p on the 20th, we'll be having a blood drive. I put the information in the chat there for you to, and we'll keep sharing that. I also want to mention that next week we have Dr. Ada Habtezian, our own professor of medicine at Stanford. She's also joining us from Pfizer as one of the, as a chief medical officer, as well as head of worldwide medical safety. She's going to be talking about the new antivirals, Pfizer's new antivirals. So we're excited to hear her talk next week. That being said, I want to turn it now over to Dr. Singh, who's going to introduce our speakers today. And thanks again to our speakers for bearing with us for all our updates. We're really excited to hear from you.
Hi, good morning, everyone. My name is Upi Singh. I'm the Division Chief for Infectious Diseases. It's my pleasure today to introduce two colleagues who are going to talk to you about the concept of long COVID. Hector Bonilla is an associate clinical professor in the Division of Infectious Diseases. He went to undergrad and medical school in Cali, Colombia, then came to the United States, did his fellowship at in infectious diseases at University of Michigan, and has been a member of our division for several years, focusing on ME/CFS clinical care. And in the last 2 years has been very, very involved in care of COVID patients, including in clinical trials. Linda Geng is a clinical assistant professor in the Department of Medicine, Primary Care. She went to undergrad at Rice University, did her MD Ph.D. University of Washington, where she looked at transcriptional control of muscular dystrophy, and then did her residency and was a chief fellow here at Stanford. That tells you a little bit about where they came from. What I like to sort of think about is where they are now. And both Linda and Hector have had an interest over several years in difficult to diagnose diseases. And I think that is sort of a perfect segue to talking about what they're doing now. They co-established the Long COVID Clinic at Stanford earlier this year, and they're going to tell us about their observations. Thank you, Linda and Hector.
Thank you so much, Dr. Singh. And thank you, everybody, for having us here. So I'm going to share my screen. Okay, can everybody see this? Okay, great. So again, thank you for this opportunity to talk about long COVID, a brief update, and also to talk about our own experiences here at Stanford post-acute COVID-19 syndrome, or as we call it, PACS Clinic. And so in terms of disclosures, Dr. Bonilla and I are both part of the United Health Group Advisory Board for Post-COVID Initiative. It does not influence the content we're about to present. In the first part of the talk, I'll give a brief, our group will give a brief update about the current definitions and comparison with other viruses, as well as the leading ideas about the pathophysiology and the current clinical guidelines. And then afterwards, I will focus a little bit about our own experiences and our preliminary data, including our care model, as well as what we have learned so far and our future directions. And then Dr. Singh will also finish with the information about the NIH Recover study, of which we are part. So we know that long COVID is a big public health problem. In this NEJM article that came out in the summer of last year, we can, they estimated conservatively that we could expect more than 15 million cases of long COVID coming out of this pandemic. That is certainly not over yet. And long COVID, because of the population, typically tends to also impact those who are in their prime working years, will have cast a long shadow on our healthcare system and our economic recovery. This is not just a national problem, but an international one. The UK, from their Office of National Statistics, estimates about 1.3 million people in the UK, about 2% of the population, have self-reported long COVID as of December 6th of 2021. So you can see that these are staggering statistics. And I will now turn it over to Dr. Bonilla to answer the question, well, what does it mean? What is long COVID exactly? How do we define this?
This long COVID definition hasn't evolved over the time. The CDC and the NIH define these COVID conditions as persistent symptoms beyond 4 weeks of the initial presentation. However, later on, the National Institute for Health and Care of Excellence, they have two categories. One category they call ongoing symptomatic COVID that include people with symptoms between 4 to 12 weeks, and the post-COVID defined as a symptom that persists beyond 12 weeks. More recently, the WHO in the Delphi consensus in October of this year, they have a meeting that involved researchers as well as advocates for these kind of conditions and try to get in any consensus about how to define these kind of conditions. And then they find a patient who has symptoms that go longer than 3 months, and after the 3 months persisted longer than 2 months. And those symptoms cannot be explained by alternative diagnosis. But however, and those definitions will continue to evolve as we continue to learn more about this illness. Next. So this post-COVID condition have many flavors, many faces, and people that can present with fatigue, that can be sometimes very incapacitated, interfere with this person's life, or people present with respiratory problems, with dyspnea, cough, or persisting requirement of oxygen, or people present with brain fog, disturbance in the sleep, anxiety, and headaches, or cardiac issues such as palpitations and chest pain, thromboembolic events, or kidney injuries. However, we see in our population even mix of those kind of symptoms in a single population. The question is how we can call all these post-COVID conditions. So the names have evolved like a definition. Initially, it was called the long haulers, then long COVID, post-acute COVID syndrome. But more recently, Dr. Anthony Fauci proposed to call post-acute sequela of SARS coronavirus. Then in some way, many people want to adopt this kind of a name because it's as a consequence of this viral infection, many people end up with multiple problems. Next. But sometimes when we apply all this kind of post-COVID conditions, it's very difficult to put a line between what is post-COVID and what is other conditions, especially in the people who have been to the hospital with severe or critical and long COVID infection, when we see an organ damage in the lungs, when the virus can cause inflammatory response, I end up with a pulmonary fibrosis, or people present with a thromboembolic events, pulmonary embolism, or strokes, or a multisystemic inflammatory reaction that can present in kids as well as in adults, then people present with a cardiopulmonary issues. However, people in the hospital, they have exposed to many problems. People have been in ICU, intubated, tracheostomy, antibiotics, getting super infections, and those kind of multiple interventions can lead into an additional problems or complications, something we call the post-intensive care syndromes, or people they can present with an autoimmune disorder such as Guillain-Barré. Next. So, but in contrast, how often do you see post-COVID symptoms in people that are asymptomatic or people with a mild form of this illness? So this was addressed in this study done, is a meta-analysis, try to review a study done to report people with asymptomatic and mild COVID cases and looking for the prevalence of these conditions in these populations. And this study looking data from December 2019 to September 2021. And they found the post-COVID syndrome, they can be as frequently as 30 to 60% of those patients who have asymptomatic or mild forms of COVID. And this kind of symptoms occur more common in females. Next. So, but the question is, this kind of post-COVID syndrome is not only unique from the COVID-19 or SARS-CoV-2. The study is looking for the outcomes in patients who had SARS in 2003 and MERS in 2012. They are then belong to the same beta coronavirus family. So in this study, they review initially our 1,000-page papers looking for outcomes, and 20 of them were included in this systematic analysis. And they found, I find that they are overlapped the finding that we see in this current pandemic virus. The decrease of the DLCO, reduce the exercise capacity 6 months after the discharge from the hospital. In 1/3 of the patients, they can present with a PTSD, depression, or anxiety disorders. And when they use the SF-36, they found in the long-term impairment of the physical, mental, and social and functional capacity. In this plot of a right plot of the symptoms is the SF-36 that show in blue, they are in the normal population, and in green are people who had over 6 months of symptoms that show how much compromised are the physical, mental, and social function capacity. So, but the question is, if this kind of post-COVID symptoms is only related only with coronavirus, or other viruses can influence the same characteristics. In this study use the TriNXX analytics. It's an anonymized data from 59 healthcare organizations in the United States that include around 81 patients. In the retrospective analysis, they reviewed the medical records in 2020, and they identify around a 250,000 patients has survived COVID, and around 100,000 patients with influenza. And they plot the symptoms that are more commonly associated with long COVID at 3 to 6 months after the infections. And they found interesting is a correlation between those symptoms and the evidence of post-COVID infections. And they found in the people who have a COVID test positive, 37% experience at least one post-COVID symptoms versus 29% in the patients with influenza. In the right upper corner, we see this Kaplan-Meier path, and we see the difference between patients with COVID-19 and influenza. And in the lower, in the radar plot, we see there are more symptoms in patients with a COVID positive versus patients with influenza. But I want to make emphasis, people with influenza can present some symptoms that overlap with the symptoms that we see in patients with COVID-19. Next. So the question is, what we know with the pathobiology of this kind of condition? We don't know yet, but there are a lot of hypotheses have been proposed, like an overactive immune system, or possible viral reservoir, or genetic factors. The phylogenetic factors is kind of confusing because more of the genetic data we have is in Caucasian population, and there's not too much data about in Hispanic or African American population that have been the group more affected by this kind of conditions. A possible microclot formation, autoantibodies, and mitochondrial dysfunction. Next. So in this study, it's a prospective study from Singapore. They are follow people who had COVID over the time, and they're looking for the many things. One of the things they look at in this study was the cytokine profile, and they found that in patients who had a COVID, even mild, moderate, or severe COVID, 6 months after, they have significant elevation in cytokines correlation with a healthy controls. In this study, they have 120 patients that include 24 healthy controls, and at 180 days follow-up, they found 11.7% had symptoms, and this population were elderly population over 65 years old, severe disease and no Chinese in race. So they were able to differentiate people who recovered and people who persisted in better cytokine profiles. In the people who recovered, they have a combination of inflammatory cytokines, and cytokines have to do with the recovering of the vascular endothelium. Like I indicate, the theory of microembolic events could be a key factor here in top of the inflammatory response. But they found out another group of patients who have persistent symptoms. They want to a monocyte chemoattracting protein 1 or the platelet-derived factor be associated with this kind of condition. So this preliminary data that may be a bigger study of data, they can help us try to understand this problem better. But now I present this data about what's the possibility of this problem, but what we can do about those patients. Dr. Geng, we in the practical clinic, we see patients with problems come to the clinic with problems. What thing we can offer to them?
Yeah, this is a great point because, we want to take care of a lot of these patients who have these long COVID symptoms. And right now, we have currently limited guidelines to go by in terms of our clinical management, but they will certainly be evolving as new information emerges. So I wanted to highlight 3 points from CDC's interim guidance. One is the goal is we don't have a curative therapy, but we're really trying to work with our patients to optimize their function and their quality of life, hopefully the ability to get back to work or their normal lives. Transparency is very important. I counsel all my patients up front, all my new patients that, the information is still new and growing. We don't fully understand what causes post-COVID conditions. And as new information emerges, we'll be there to provide them with up-to-date expertise. And this is really important. The symptoms not explained by or out of proportion to objective findings are not uncommon after COVID-19, and patients should not be dismissed, even if there's not yet a full understanding of their etiology or their expected duration. And this is, validation can be therapeutic in and of itself. The other guidelines that came out of the UK's health authorities, this is summarized in this BMJ article, and they wanted to highlight 3 points. And I want to just mention the likelihood of developing long-term effects of COVID-19 is not thought to be related to the severity of the acute infection. And some of the most common symptoms, for example, fatigue and breathlessness, we want to understand that there can be multiple, but also they can be transient or fluctuating and change or evolve over time, which also makes it challenging to kind of manage as well as understand other conditions and attributions clinically. And then here they also recommend imaging as well with chest X-ray for those with breathlessness within 12 weeks after their acute infection, if not already done. And then we are also part of this American Academy of PM&R consensus working group across the country. And so the group has published in August the first guideline regarding treatment that's focused on specific symptoms or systems. So the first one that came out was fatigue, and then in press are breathing, cognitive symptoms, as well as other ones in progress. And I encourage you to just take a look at those for certain consensus statements. But again, these will be in evolution and certainly updated as new information emerges. One thing I do want to, kind of point out, for example, for fatigue is really an individualized and titrated return to activity. Because so many patients experience post-exertional malaise, meaning they have significant fatigue that's worsened or feeling unwell after they exert themselves, that it's really important to take it at individual pacing and not push for a reconditioning program necessarily. And a holistic approach to making sure that other conditions that contribute to some of these symptoms are addressed. So some of the guidelines say to refer to a multidisciplinary specialized post-COVID center, and many of them have started around the world. And in the United States now, pretty much every state has at least one, and except for the Dakotas. And then across internationally, there are at least 65 in the UK and also across different continents. So what we do here at Stanford, we launched the Stanford Post-COVID-19 Syndrome PACS Care Model and Clinic early last year. And so we receive internal and external referrals from the community as well as internally at Stanford for patients who've had a prior COVID infection, with any kind of positive test, as well as persistent symptoms more than 4 weeks. And for those, of course, we understand there are access issues to testing, such as right now, and certainly early in the pandemic. And I think without, with our backgrounds in patients who had puzzling symptoms after infection, we also try to see patients as well who don't have necessarily positive COVID tests due to our capacity in the PACS clinic, in the chronic fatigue clinic as well. So in our portal or hub, as we call it, this is where all patients get their evaluation initially by one of ourselves in the hub clinic, myself in internal medicine, Dr. Bonilla, infectious disease, as well as Dr. Bob Schaefer. And they undergo standardized assessments, laboratory studies, as well as global evaluation. And they may be offered opportunities to enroll in research studies. Depending on their individual clinical presentation and needs, we may refer them to one of our subspecialty team partners who see post-COVID patients. And this becomes, our team, our multidisciplinary team, to try to address the patient's symptoms. And it's very important that we maintain this partnership with their primary care provider as well for longitudinal care and follow-up. So this really, we're so grateful for our incredibly, experts, as well as multidisciplinary group of physicians and clinicians who take care of our post-COVID patients, including across specialties in internal medicine, as well as across other departments of neurology, psychiatry, otolaryngology. And I wanted to highlight some of the unique expertise that is here at Stanford, including in the autonomic area. So Dr. Nicholas, he's a leading expert in post-COVID POTS, in particular, postural orthostatic tachycardia syndrome, and has published this nice review article on the long-haul autonomic complications. As well as Dr. Zara Patel, who is a really renowned surgeon, researcher, and she's published widely about olfactory dysfunction even prior to the pandemic. And she has this wonderful, very educational piece in JAMA Otolaryngology about smell rehabilitation and training. And this is something, I think smell and taste loss is actually one of the still persistent symptoms that are very much seen in our long COVID population and can have significant impact on their quality of life. Not being able to enjoy food, having weight loss secondary to it, anxiety, depression because of the interference with their social lives, and even safety considerations as well. So our hub clinic, we've seen over about 140 patients so far. I'll share some preliminary data on our first 100. And we do a 29 symptom survey, as well as assess risk factors and their functional status. And orthostatic vitals are done as a standard assessment as well. And basic lab screening we do as well, which are part of some of the guideline recommendations. Other labs are done as indicated, but really we found that a tailored approach is likely best because of such heterogeneity in our patient population. So what we have learned so far, I want to give this a moment to just recognize our fantastic, very talented Stanford research students, Tom Kwok and Anisha Tiwari, who are really doing a lot of the groundwork on this data. So our clinic demographics, this is an analysis from the initial 100 patients we're adding to this as well. We find that 63% of our patients are women and 37% are men. This is consistent with a lot of the other studies that have shown a female predominance in folks who have persistent symptoms after long COVID, and usually around this ratio as well. In terms of race and ethnicity, so in our clinic, we have an underrepresentation of Hispanic or Latinx folks who identify with this background. And this is in comparison. So this is about less than 20% in our patient population versus about what's reported to be 50% of total COVID-19 cases in California. And then here in contrast, we have those who identify as white are about nearly 50% versus the 26 total cases in California. We don't know what accounts for this, whether it's access, referral, or structural equity issues, and then, or is it truly that patients of the Hispanic or Latinx community have lower rates of long COVID? That should be studied more rigorously. Our age distribution is quite broad, but you can see that there is some clustering in the younger age group, and the average age is 46. So in terms of comorbidities, about a third of patients, if we look at all our 100 patients initially, 35% had no known prior medical problems. They were totally healthy. They did not have any comorbidities. And even when we look at the 65%, so we count folks who have had history of migraines, they may be well controlled, hypertension, who are controlled on medications. And many of those who had past medical history were living robust, very active, high functioning lives. And 84% were not hospitalized for acute COVID-19. These findings, asterisks here, are similar to a Mayo Clinic cohort study as well from their post-COVID follow-up group. And the highest association in terms of select comorbidities was a BMI greater than 30. So in terms of when we think about how healthy, relatively speaking, our population was prior to COVID, and we think about the duration and the functional status that they had at the time of presentation to our clinic, we see that first there is a broad range of duration of symptoms at the time of their first visit. It averaged around 9 to 10 months, so nearly a year. And the longest patient had about 21 months of symptoms. And symptoms, really this emphasizes symptoms can last beyond a year. And when we think about how long that is and their functional status, these stages are based on a modified from a paper that was published for post-COVID patients. And stage 1 is no symptoms, stage 2 is symptoms, but without functional limitations. Stage 3 is that they have to avoid some of their daily activities. Stage 4 is they're really struggling to do basic ADLs. And then stage 5 is they're essentially bedridden. And we see that a significant portion, 81%, are stage 3 or above. So they experience significant disruption to their daily lives. And nearly 1 in 5 are struggling to care for themselves or in bed almost all the time. So this is significant impact and consistent with what is seen in the literature recently. And so I'll highlight 3 studies here. One is by Tabikoff and colleagues, published from their, this is Mount Sinai's and their post-COVID follow-up group. And they had surveys for median follow-up about a year. And it was pretty significant in terms of loss of work. 20% were still unable to work due to their illness, not because of other factors, but because of their illness, and a significant reduced quality of life and functional status. This large study by Davis et al. Showed that for greater than 91% of patients, recovery exceeded 35 weeks. And similar statistics, about 20%, 22% were not working at their follow-up. And I wanted to point out that, and so if we look at this, I mean, these are pretty, when we think about the staggering statistics of how many people may be impacted from our pandemic with long COVID, and thinking about not just right now in terms of acute COVID and staffing shortage and work impact, but also long COVID. And it's extremely, potentially long duration in some individuals. A high proportion of those can't function and return to work, as significant social as well as economic impact on productivity, and just a lot of trickle-down effects from that as well. And I wanted to bring up this interesting, very unique paper. It's actually looking at on the field performance of elite athletes. So these are pro soccer players in elite leagues in Italy and Germany. And they assessed with a reduced performance of pro soccer players at 5% lower than over half a year later relative to their pre-COVID infection outcomes. And, and this is, I just want to mention this because it's a point that long COVID impacts can really affect anybody. And that we keep this in mind when we think about the stigma and the sort of historical bias against, unfortunately, young women, and particularly young women of minority backgrounds, as they present with puzzling symptoms and functional debilitation with postmortal syndromes. And keep in mind that, when we think about assumptions for that patient population, would we think that as well for somebody who is young, healthy, elite athlete male, who also is impacted by these, by something we don't fully understand yet. So now I'll talk about the specific symptomatology for long COVID that we see in our clinic. So many of you probably see this very striking image published by Lopez Leon and colleagues. And so this is their a review and systematic analysis of published papers on long COVID symptoms. It's really overwhelming. There's so many symptoms. But some of the top symptoms, pop up over and over, including fatigue, headache, etc. When we look at the complexity of our patient group, Similarly, we do find that we have, ranging minimum to maximum numbers of 1 to 24 per patient. And the average median number of symptoms is about 12 per patient. And the number of patients with more than a dozen is 47 out of 100. Now, it is important, of course, there are sort of limitations and things to consider and critiques about survey-based studies in terms of recall bias, selection bias, and possibly reported symptoms that could be attributed to other conditions. So that's really important to consider as we do a comprehensive evaluation for our patients, to think broadly, to rule out other conditions and make sure there are not multiple contributing factors that are not long COVID first. And when we rank our symptoms from our cohort from the most common, and we look at the 15 most common: fatigue, brain fog, post-exertional malaise, daytime sleepiness, this list is very similar and consistent to other published data as well. And I will mention brain fog is, is a commonly used patient term, but it can encompass a lot of different cognitive domains, including memory, processing, attention, as well as language. And so I think this may be further delineated as well as we do more rigorous phenotyping. And so this is a recent review article, and as you can see highlighted, the similarities with our list as well. And I also want to mention here that many of these symptoms are non-specific, and they could be, and they're very interrelated, right? Could somebody have fatigue and difficulty concentrating because they have a lot of sleep disturbance? Or is it because of a lot of the anxiety and depression that they're experiencing, or both? And there's certainly layered effects and complex interplay, again, emphasizing the need for a very holistic approach, as well as rigorous clinical phenotyping and understanding of correlation versus cause and effect. And I also want to mention here, it's kind of interesting, this is our preliminary data, so we'll be adding more, but this cluster of respiratory and ENT symptoms seem a little bit more predominant in our female population, but we'll be adding to this doing further analysis. So when we also look at not just the most common symptoms that people report, but the most severe on our Likert scale of 4 to 5 that they report as most common, the list remains about the same. Still, the fatigue, the post-exertional malaise top of the list. The nasal congestion and cough are replaced by sweat and chest pain, but otherwise the leading symptoms remain the same. And so now I'll turn to Dr. Bonilla and ask, when we look at the list of fatigue, brain fog, post-exertional malaise, and unrefreshing sleep, what comes to mind? What is this reminiscent of?
So indeed, I feel like was deja vu here, and when I working in my chronophytic clinic is what we see here. As you know, chronophytic syndrome is as an illness has no laboratory diagnostics, and the diagnosis are based on clinical criteria, and those criteria have been evolved over the time. The more recently criteria is the IOM or intensive medicine criteria in 2015 that use 5 different kind of categories to call this syndrome as a chronophytic syndrome that include severe incapacitated fatigue that interfere with those people's life, professional, social, complete change their life for life. And the symptoms of fatigue persist longer than 6 months. Other decoration association with fatigue include the unrefreshing sleep. People sleep hours and they wake up in the morning like I didn't sleep at all. The post-exertional malaise or crashes that the people call people after physical activity, stress, or too much overstimulation lead to exacerbation of the symptoms. And one of the 2 symptoms, the brain fog or the cognitive dysfunction that have been shown in those patients, were able to think, memory, concentration, process information, speed of process information is compromised in those patients, or even evidence of dysautonomia, like orthostatic intolerance. Sometimes people present like a gastrointestinal symptom, diarrhea, constipation, severe nausea, or episodes of orthostatic intolerance, or in the extreme case, PACS. Here, when we look at our data, I look at the data, I say, wow, my God, it's a deja vu, what we see in our patient with chronic fatigue. And they are, so we decided to see if those people fit into the criteria with chronic fatigue. So we decided to do a study in our population, next. In this study, we look at 109 patients from our clinic. And 15 they were excluded because they had not enough data. The test was not confirmed positive in those patients, only based on the clinical symptoms. And other people have a history of chronic fatigue before they're going to be enrolled in the clinic. So we end up with 94 patients, and we decided to apply the criteria of longer than 6 months of symptoms. And we end up with 70 patients than with the final analysis of this study. So in the patient, we apply other criteria in top of the diagnostic clinical criteria, the IOM. Then we include the functional status 3, 4, and 5 that has some limitations to severe incapacitated or bedridden, or fatigue than in between severity 4 and 5, plus the IOM criteria. When you use those criteria, we identify 56% of our patient population, the study fit into the phenotype we call Chronophytic Syndrome. When we look at this kind of groups of patients in this table in the right, a little bit kind of busy slide, but we saw the age is similar, the sex, which are a predominant of female, and something not expected because majority of our population is females. But when you're looking for what have been reported in the literature about Chronophytic Syndrome, is a condition affecting more females than males. And white population is a reflection of what the study is, or I don't know, it's a reflection of disease affect this population. But here in Stanford, in our clinic, the white population is more frequent than we see in our populations. And something kind of very interesting was majority of the patient, over 80% of the patient has a very mild or moderate COVID, and only a few people were hospitalized. I don't know what this means. It means maybe people hospitalized could be a protective factor about this condition. We don't know, but it's an interesting findings. And majority of the patients that we see with chronic fatigue, they are healthy individuals without any problems, or one or at least 1/4 of the people, they can present with just one single comorbidity conditions. And we're looking for obesity is one of the factors that have been identified. We're looking for BMI greater than 35. 7 of our patients with the chronic fatigue have BMIs over 35. And the criteria, majority of the people, 75% of the patients fit in all the 5 criteria for chronic fatigue, and around 1/4 have only 4 of the 5 clinical criteria. Next. So, but it's important to see what lesson we learn from the chronic fatigue that can be extrapolated into the post-COVID syndromes. And we know in people with chronic fatigue has a persistent inflammation. A big study came from Stanford a few years ago. They're looking for a big population, over close to 200 patients with chronic fatigue and 300 controls. And they found elevation of inflammatory cytokines, more specific TGF-beta high and low in resistance, but they found out 17 of the 51 cytokines correlate with the severity of the illness. With the higher levels of cytokines, the worse are the symptoms from those patients. These are plenty of studies that are consistent in trying to identify the NK cell function that have been reported low, that have been able to report low in patients with acute COVID, and both are linked with TGF-beta. Brain inflammation have been reported in several studies in chronic fatigue patients using PET MRIs or magnetic resonance spectroscopy. Then they show a specific size of the brain compromised in this kind of populations, and evidence of mitochondrial dysfunction reported in chronic fatigue, and have been already reported in patients with acute COVID, but nothing reported in long COVID population. And some studies that need to be completed for better understanding about this illness. Next. So, but there are tendency to try to put this patient in different categories or subtypes. People with a no severe COVID-19 or pulmonary fibrosis or chronic fatigue syndrome, PACS, or patient post-intensive care syndrome, or medical or clinical sequela. When every patient that we see in our clinic present with 1 or 2 a majority of the people is a combination of many of those kind of symptoms here. So we believe Dr. Linda, again, and myself, in our patient population that we see in our practice, there are people that symptoms overlap, and we believe possible is a spectrum of the illness more than different kind of subgroups. If you look at the H2 receptor and distribution in the whole body, you see almost in every single organ has expression of this kind of receptors. And the autopsy findings, they found out evidence of virus in multiple organs, and more specific, with a higher amount of virus in the respiratory tract. Next. So the question is, many of my patients I see in the chronic fatigue clinic as well as in the post-COVID clinic, they are kind of reluctant to get vaccinated because they are concerned about potential side effects of the vaccination. Dr. Geng, what you can tell about these things in our patient population?
Yes, thank you. And I think we're running up to time, but this was one of the most common questions asked so far in the chat. So I'll go over this. Our own data shows that in our 100 patients, 89% had received a one dose of COVID-19 vaccination, most after their initial infection. So we're asking the question, what happens to patients in their long COVID symptoms with vaccination after their initial infection? So of these 89 patients, 63% had no change. So the majority of our PACS patients had no change in symptoms after their vaccination. Unfortunately, 21% did feel like they significantly worsened in terms of their long COVID symptoms, and 11% reported that it helped. Now, there's limited published data out there to compare our data, but we will add this and have further analysis. Now, if we flip the question and ask, okay, what if you have vaccination before you get COVID, and what are your chances of getting long COVID then? In this large UK-based study, I recommend to take a look at Antonelli and colleagues in Lancet Infectious Diseases. This is a self-reported mobile phone app for a symptom report. And they looked at a large population, 1 million folks who reported first dose, very low breakthrough rates as expected, lower symptoms and less severe disease as expected. And here's the interesting part is the odds of symptoms lasting greater than 28 days were halved with 2 vaccine doses on board compared to those who weren't vaccinated. So, this is not, how we define long COVID and everything will influence how we really conclude about this. And we need to look at different vaccines, have different populations and for more conclusive data. But this is encouraging to start. And in terms of prognosis, I just want to sort of wrap up here. This one big study from Wuhan looking at 1-year outcomes really still showed significant symptoms in their hospitalized survivors, significant mental health comorbidities. 88% were able to return to their original work, but still 12% didn't. And so in our preliminary follow-up, is there a light at the end of the tunnel? We had, this is low number, so we need a further follow-up, but at 1 to 3 month intervals for follow-up 1 and 2, most people were either unchanged or improved. And so that's encouraging as well. And some people, because we had a wait list, by the time they had their first visit, had actually improved on their own minimal symptoms. So that's very encouraging. But we should be cautious because in SARS, as Dr. Bonilla presented earlier, which has parallels to our COVID pandemic, is that in 2009, they published a 4-year follow-up. And unfortunately, there was still a significant portion who had chronic fatigue and those comorbidities. So it's a precautionary tale for but only time will tell in terms of what our long-term outcomes will be. So this is a summary of our findings so far. Younger patient population in general, women, and mild to moderate disease, previously healthy, making up a significant portion of our patient population, and having significant functional debilitation. Half of our patients fit the criteria for ME/CFS, and vaccination had no effect on the symptoms for most of our PACS patients. And although some have symptoms greater than a year, I do try to provide some optimism that patients do get better over time. Briefly, just for our future directions, we'll be continuing to expand our collaborations and pursuing research studies looking at our specific subpopulations and looking at there's an urgency to look at rigorous clinical trials for potential therapeutics and repurposed medications, of which we are part of a collaborative to design a platform clinical trial across the country. All right, and it really takes a village. So I want to thank everybody, and Dr. Bonilla and I are so grateful for our students, collaborators, our research teams, and of course our staff and our leadership and all the teams behind the scenes that helped us build this. And last but not least, our patients who partnered with us and learned from in this journey. So thank you, and I'll turn it over to Dr. Singh in the last few minutes.
Thank you so much, Linda and Hector. I think actually if you go back one slide, we'll end with your presentation. And there are a lot of questions in the chat, and I can talk about the RECOVER study at another time.
Okay, all right, thank you. Well, thanks everyone. Sorry to kind of rush at the end. I know many of you have other obligations. Let's see.
I just, well, Dr. Geng, I apologize. You know, we had so many updates. You guys did an amazing, a ton of information in a relatively shorter time than we'd even initially given you. So thank you for doing that. And really thank you to you both. Dr. Singh, thank you as well for being with us. And I apologize, we didn't give you enough time to talk about RECOVER. Perhaps we can have you update that next week as well on the RECOVER trial that we've been meaning to do for some time. So thank you for sticking with us. And I just wanted to get, you know, I know we're a little bit past time, but if we could spend a few minutes on some questions. I know that we already have questions being answered right now. Dr. Bonilla, thanks for going into chat and also answering some questions. There has been a couple of themes. The big question, of course, has been, of course, Omicron. And I know that Dr. Bonilla, you mentioned that there isn't any data. I wanted to just get your kind of expert opinion, your sense of Omicron, how it may affect long COVID or not affect long COVID. Any thoughts on that?
I think, Errol, this is too early to get any conclusion. I don't like to guess because when I guess, I'm wrong. So we need to wait for the data. And I'm going to keep my fingers crossed. There's no higher because we see the rate of infection with Omicron so high. And we see in our population, majority of the people have asymptomatic or mild COVID, and they present with this kind of sequela. Something that I am very concerned about it, and the lacking of people and resources that we have, because we need to address this problem, because a big problem, a big tsunami is coming in a few months from now, and how we can care for this kind of populations, looking for alternatives for diagnostics and alternatives for therapeutics. It's some problem that we are going to face it after we continue working hard, try to find solutions for this kind of problem. I didn't answer your question, but the answer is, a short answer is no, I don't know. And I hope it's not going to be bigger.
It's a fair answer. Dr. Geng, any other comments?
I totally agree. There's so much more data we need to gather, and I think time will tell for the Omicron.
Fair. Another theme of the questions was about vaccination status, and you touched on that. Any other comments? There's just a lot of questions on how vaccination status. Dr. Marin and Dr. Siegel had asked. Any other comments regarding that?
The biggest study that we have is that UK study right now. I think there are some in preprint, but I also hesitate to kind of make conclusions from those. But it's looking encouraging so far in terms of vaccination. But again, the question remains, as new variants, you know, what's that going to do, and what type of vaccinations? And that was not a very diverse population, so we need to be able to have more studies to really make inclusive.
Got it. Got it. I might go to one last question here, and I'll try to wind it down. Dr. Alwali asked a question about pediatric long COVID. Any comments on that? What do we know?
I don't have no data about long COVID, but we see a having report long COVID in pediatric population. I know Stanford have a clinic for long COVID in pediatric population. I cannot answer from them. I think maybe the question, maybe we can defer to the pediatric team, what they see in this kind of population, what are the prevalence of symptoms, what the population, and look at what mirror us, and if they are some the same findings that we have, reflect what they have seen so far.
Yeah, and there is definitely, as you know, the challenges of studying more rigorously for the pediatric population, but there is some data to show that there may be similar effects as well, issues with fatigue and difficulty with attention and disrupting their schoolwork. But it seems that the rates are lower and perhaps not as prolonged, but I think more data is needed there as well, and certainly from our pediatric experts who can comment on that.
Well, there's a lot of great questions here. I'm really, I wish we had time to get to, especially again, stuff like chronic fatigue syndrome similarities and things you touched on a little bit. If it's okay, I might send these questions to you. If there's any you want to answer, we can, like we've done this before many times in the last year or two, is we can, with the follow-up email, when we have the recording of this, we can answer those questions and send out as well if you'd like. So I'll send those to you as well. Any questions you'd like to answer, we can address from there. I just want to thank you so again for being with us, and thanks for everybody for sticking with us as well. And I hope you have a great week, and we'll continue to keep you updated.